Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James. Today I'm delighted to be joined by Rob Deans, who is a Physician Associate in Acute Medicine. Welcome to the podcast, Rob.
Thanks for having me, James.
I wanted to make an episode about acute medicine because it is, I think I'm right in saying, according to the FPA census, the specialty in hospitals which employs the most physician associates across the UK. So it's a really popular one that lots of PAs work in, I think. I myself split my week half between GP land and half in acute medicine, but it would be a bit boring, I thought, to interview myself. So thank you for coming on and talking to me about PAs in acute medicine. Do you want to introduce yourself and tell us about you?
Sure. So, my name's Rob. I've been a PA in acute medicine for 3 years. It's the only place where I have worked. So I graduated 3 years ago from Manchester University. And a lot of my placements whilst I was a student was in acute medicine. I was only meant to have a rank 1, but I ended up, just the way things happened, I ended up having around 3 placements there. And I enjoyed it. I thought it was a good experience of a wide variety of conditions. I felt like I had enough experience from my student life. I've been exposed to acute medicine quite a lot. So it felt kind of natural for me working for acute medicine. And the progression that you see, it's very hands-on, you get to see a lot. And in the proof of the pudding's in the name, I guess, it's acute. And I enjoy that. I very much enjoy the acute management of patients, quite enjoy the unwell ones and the ill ones. The social side of medicine, I'm not that keen on. It's very important. The whole waiting package of care and things like that. I'm not too keen on that, but I am keen on the deteriorating patient, and that interests me. And then the job kind of came up. It all fell into place for me.
Perhaps there might be students listening who might not appreciate some of the differences between acute medicine and emergency medicine and other related specialties. Do you want to sort of explain what acute medicine actually involves?
Certainly. So, I've never done a stint in A&E. Obviously, as a qualified PA, I think their role is to stabilise the patient and refer to the right specialty. In AMU, a lot of the time is spent on trying to, I think, bridge that gap. So the patient is, let's say they're too unwell to go home from A&E, they might need a day or two to get better whilst they're in hospital, and that can happen in AMU. They could stay for, again, a day or two in AMU whilst they are waiting to be moved on to a different ward. And basically making sure that acutely unwell patient is starting some processes, I guess, that can be followed on down the line. You'll see patients who have maybe got some red flags in their history. You can treat them acutely. Let's say you've got someone who's coming for unilateral pleural effusion, for example, smoking history. In AMU, we would potentially do CT scans, look at doing a drain, start that referral process, a 2-week wait, and then the patient is moved off to, let's say, respiratory ward, ideally. So I guess the difference between AMU and the emergency department is the emergency department will get a wide range of presentations in terms of pediatric, surgical, and medical, trauma orthopedics. For AMU, it's just filtered down, so you will just have adults and it will be medical patients. So we don't see surgery or TNO primarily. I guess a nice thing about AMU is you can still see elements of that. For example, if someone comes in with a fall and they've broken their arm or something like that, you still will see a bit of collaboration between different specialties, which can be nice, actually keeps your feet wet in different specialties, I guess.
If you're able to sort of generalise it, what kind of presentations do you see a lot of in acute medicine? Are there certain things that come up quite frequently?
So there are definitely things that come up frequently, and that depends on the setting that you're in. So in AMU, there's a lot of chest pain. there's a lot of respiratory COPD exacerbations, things like syncope that comes up quite a lot. Upper GI bleed is a common one that we'll see, which is really good because you do get a broad variety. In our ambulatory care, you get more of the nuanced presentations, often a lot of headaches, often things like numbness, tingling, other things as well. But and ambulatory care is satisfying in its own way and in a very different way. But I would say there's different things for different areas. So ambulatory care is more nuance.
I was just remembering when I was a student, I'd never stepped foot in a hospital before, and I didn't really know what everything was. And I looked at the ambulatory care side, and I assumed that was something to do with ambulances for a long time until someone explained it to me. Actually, we should probably clarify for those who are in the same boat. Ambulatory care basically meaning people who are adults with medical problems who are kind of able to walk in and fit to sit in a chair rather than needing a bed or a trolley for assessment. And the idea being hopefully that they can be sorted out same day with luck and further investigations planned on an outpatient basis rather than being admitted to the hospital. Take me through, or if you would, walk me through what a normal day in your acute medical unit looks like as a physician associate.
So my day starts at 8 in the morning. We will go for a walk around with a consultant. So for me, it will be me and a consultant. We will tend to see 12 patients, give or take. These often are different patients every day. That lasts until maybe midday, and then after that we will do the jobs for those patients. I find that provisionally I can do most of the jobs that are needed. If there are things that I can't deal with, there's lots of registrars or the junior doctors around who I can pinch for advice. Every now and again we'll get something through the door like specific taps, pleural taps, LPs, which we all get a hands-on approach to. I'm quite heavily into the ultrasound, so I'll quite often use an ultrasound on the ward round. Occasionally as well, we will be on the ambulatory care side of things, where we'll see a shorter ward round of around 6 patients and then see ambulatory patients in the afternoon. And again, occasionally we will go on the medical take. So they will start at 8 o'clock in that time and go to A&E and see patients on the medical take and wait for them to be post-take by the consultant, which is all of them have a great way of learning and developing in their own different way.
Sounds very similar to how it runs in my AMU as well. I think across the country, a lot of the units should work in a very similar way for patient flow reasons, shouldn't they?
Yeah.
You mentioned ultrasound. Do you want to tell me a little bit more about what you've learned and how you use your ultrasound machine in your clinical practice?
Yeah, so I use my ultrasound machine, I wish. I use the ultrasound machine a lot. Nearly every day I'm using it, to be honest with you. I've used it for DVTs. I've spotted kind of one of my moments that I suppose I was proud of as a PA was I was on the late shift one night, and had a lady who had quite advanced breast CA. She had a CTPA around 2 weeks ago, which was negative for a PE. She came in desaturated quite a lot, 60% on air, and it was me and a registrar on the late shift. The registrar was busy with another patient. I got the ultrasound, put it on checked her legs out for any DVT. Saw the clot, went on to have a CTPA, showed a PE, and that was a real kind of eureka moment, I guess, for me. It was a real benefit of ultrasound. I thought just fantastic. You got your diagnosis in a few seconds. So I use ultrasound a lot. I'm famous accredited, which stands for Focused Acute Medical Ultrasound, which is a point of care ultrasound standard, which allows me to look at patients' lungs, their abdomen, and their venous system for DVTs.
I guess one of the things that might scare people off acute medicine, or at least feel a bit intimidating, perhaps as a student, if you're picking jobs, is you are in the area of the hospital where you do get some sick patients. They do deteriorate. They do come through the door quite unwell. Was that something that you had to learn to be okay with? What other courses did you do to help you manage the acutely deteriorating patient? And how has your confidence and expertise in that area grown with time?
Good question. I think time and experience are factors that are invaluable. There are courses, obviously ILS, ALS, they certainly help. It is daunting being in acute medicine because you do have those acutely unwell patients. And that is why it's important to know your limitations and to know what you can handle and what you can't handle. I always say, the eyes can't see what the brain doesn't know, for the word. So always be willing to ask for help. There's always seniors around. In AMU, there should be it junior doctors, registrars, SHOs, consultants. So if you are worried about a patient, then you need to escalate it because patient safety is the number one priority. The good thing actually about escalating a patient is you can see how others handle the situation, and you can learn from them and say, well, last time I saw this good clinician treat this condition in that way, and therefore I think we should look at maybe potentially doing the same. You get to learn and develop. And one of the advices that I would say actually from if I were to say to any students or people going into AMU is sometimes to actually take away your clinical brain and just see this patient in front of you as a person. I think we the common sense sometimes can get overlooked in medicine. And if you look at a patient just as a person, go, they look unwell, they look okay, and you can experience and time will kind of do the rest, I guess.
I like that. That's really good. And you're saying about the eyes cannot see what the brain doesn't know. I like that. I'm going to take that one away, definitely. Oh, brilliant. Thank you, Rob, for explaining that to me. So I know there is a Society of Acute Medicine, isn't there, called SAM. Do you want to explain a little bit about that?
Yeah, so it's a great society for those in acute medicine or have an interest in acute medicine. They will provide journals and articles for you to read to keep up to date. They have conferences, so they recently had, it was in October, SAM conference in London, which was a 2-day event with talks from people of all specialities, which is really good just to do a few things. Primarily keep up your knowledge in acute medicine, find out anything new that is coming out on the market, and equally networking as well, being honest with you. You're going to see lots of different people from different hospitals, and you can see how their acute medicine unit works and pinch ideas from them and see what works for them, what doesn't work for them. And yeah.
Perfect. Thank you. I wonder how you see your career, perhaps yourself as a physician associate in acute medicine, but also maybe more generally for PAs in acute medicine, how you see that evolving over time and what might come next.
Yeah, I think there is certainly careers in acute medicine for PAs. Like you said, it's one of the, if not the most employable areas for PAs, and with good reason. It is a busy ward, requires a lot of time and energy, and with that comes a lot of responsibility. And having a PA on that ward who can help with new turnovers of staff, knowing the flow of the ward, knowing who to speak to is really invaluable. So I know that our consultants value our PAs. So I could review patients on a ward round, maybe let's say 6 patients, I'll take a bay. I will do that ward, do that bay, and speak to the consultant afterwards and say, this is the patient, this is what they're coming with, this is what I want to do for them. And that's really good. That really helps you to learn. And that's beneficial for everybody. It's beneficial for the consultant because they have their ward round is seen quicker. They can do more admin staff and things like that. It's beneficial for me because I learn a lot more. There's certainly a big difference between whenever you are, shall we say, the PA on a ward round with a consultant and you are following their plan. That's a lot different to seeing a patient by yourself and having to formulate a plan by yourself. And that helps you to learn. It's a steep learning curve, but it does help you learn. And I think the patients like it as well, because whenever I do a ward round by myself, if I'm seeing a baby by myself, then I tend to spend quite a bit of time with the patients, which they like. I think they feel valued, they feel listened to. I've got plenty of opportunity to develop my procedural skills, being really hands-on with my approach, which I love. If you want a hands-on approach to medicine, then AMU is a good place to be.
One of the limitations at the moment of being a physician associate is a lack of regulation. We're unable to order x-rays or CT scans, ionising tests like that. And we're unable to prescribe as well at the moment. AMU is a very busy part of any hospital. And I wondered if you could just tell us in practice whether those limitations sort of get in the way day to day or whether you're able to overcome those obstacles in reality.
I think overall, I don't think it's a big problem. I think it would be good personally for physician associates to be able to prescribe in the future. But currently, as it stands in my role, I don't think it limits what I can do. If a drug needs prescribed, then the doctors are always on hand to help with that. And it's done safely, and that's the most important thing. Whenever I ask a doctor to prescribe, I will generally give them a lowdown of what the patients come in with and why I want that medication prescribed and see what they say. And a lot of the framework of how physician associates work, especially in acute medicine, is done on trust. And one of the benefits of having a PA in the unit is they're there for a long time, and that trust then develops. So with some of our registrars, for example, who have known me for nearly 3 years, they trust me, and that makes the process a lot easier. If you've got a new F1 and they're a bit more skeptical, I think PAs have to be humble and have to be patient and realise that at the end of the day, this is a doctor putting their GMC number down on the paper, and we have to be respectful of that. But in day-to-day practice, I don't think that it holds us back from being effective. So I do believe that in the future, if we were to get prescription rights, we would be able to be more efficient at our job.
It's true. I know the medical consultants who I work with in my unit often speak about the value that PAs had around junior doctor change over time. So certainly in August, when all of the doctors are new into the hospital, but even at the midpoints throughout the year, when there are new faces coming onto AMU all the time, the team can change. Day to day, you can be a totally different medical take team, new registrars, different juniors, different consultants. So having physician associates as part of your team is really important, actually, for a bit of continuity, isn't it? To show people how things are done and to get the referrals done in a timely manner and where things are kept, and those kind of practical parts of the job as well, aren't there?
Yeah, absolutely. Yeah, couldn't agree more.
Rob, in acute medicine, well, I guess in any specialty, to be fair, but certainly in acute medicine, I remember being a student and being totally bamboozled by a lot of the phrases that crop up around AMU. It's kind of like learning a whole other language, regardless of learning all of medicine and all the technical terms that come with it. Could I just ask you to help for the listeners just to fire some phrases at you and just to get a good definition of what it all means in AMU? So we'll start with AMU itself. What does AMU mean?
AMU means the acute medical unit.
The phrases like the medical take and post-take, what do they mean?
So patients who are seen in A&E and refer to medicine go onto the medical take. They will then be clerked by junior doctors or myself or PA, and then they will be post-taked by a consultant later on once you have seen the patient.
So the post-take is the sort of consultant review process.
Right. Yeah. I haven't defined that very well. But
yeah, they're difficult phrases, aren't they? So there are grades of doctors, and Foundation Year 1, Foundation Year 2. Foundation Year 2, otherwise known as Senior House Officer or SHO. And then doctors tend to pick a training specialty, don't they, in a medical specialty, either cardio, resp, gastro. As they progress further in their higher training of those specialties, they become registrars, don't they, which is sort of a middle level of seniority for doctors, just underneath the consultants who are the most senior. Brilliant. Thank you, Rob. Thanks so much for talking to me about acute medicine. If people have got questions about physician associates in acute medicine or want to find out more about the specialty, where would you suggest a good place to find out more information?
Yeah, so I'd start with the acute medicine website, so acute-medicine.org.uk. That's a good place to look at. And also the Society of Acute Medicine. So that's a good place for you to look at.
Perfect. Thank you. I'll leave those links in the show notes so that people are able to find them and access them on their device. Thank you so much for joining me on the episode. And thank you for listening as well. I hope you found that useful to find out more about physician associates who work in acute medicine and more about the specialty itself. If you're a physician associate working in a different specialty, or if you've got an idea for a future episode of the Physician Associate podcast, I'd love to hear from you. Please get in touch on social media. I'm at PA Podcast UK, and I hope you'll join me again for the next episode.